for our third hearing on mental health care this year, and we're going to begin with mental health parity. For 13 years now, the Parity law has required equal treatment by insurance companies of mental health care and physical care. That law was the result of extraordinary efforts by two late senators, Senator Wellstone and Domenici. Both came from families touched by mental health challenges, and I can tell you there are a lot of senators who have experienced the same thing. The Parity law was supposed to be a game changer, yet instead, mental health patients have spent the last 13 years all too often bogged down in insurance company foot-dragging, red tape, and piles of excuses. This committee, and I appreciate Senator Crapo, Senator Cornyn, Senator Stabenow, Senator Cantwell, our colleagues are committed to fixing this on a bipartisan basis. I'll also say it's not on the docket today, but I strongly believe that more needs to be done to hold the executives of these mental health companies accountable. I'm going to give 4 examples of what's wrong. First, too many Americans are getting shoved by these insurance companies into ghost networks. When you're stuck in a ghost network, you can't get a provider to take your insurance. The insurance company's directory of providers is often wrong, often years out of date. Or insurance companies pay so little for mental health services that patients get stuck with the whole bill. When families pay good money for insurance and wind up with a ghost network, you sure don't feel like you're getting parity. You feel like you're getting ripped off. The next example, mental health patients are getting whacked by coverage limits that cut off their stays in a hospital. Health treatments ought to be driven by a professional diagnosis, not an arbitrary cap set to protect insurance company profits. Third, insurance companies are relying on loopholes to deny coverage, requiring prior authorizations before they pay for care, setting unreasonably high standards for the medical necessity of mental health care is just wrong. Particularly for somebody experiencing a mental health crisis, these bureaucratic roadblocks to insurance coverage can be fatal. If you break your arm, you don't have to make a dozen phone calls and put together a mountain of paperwork to prove to your insurance company that you got to see a doctor. A mental health crisis shouldn't be different. Fourth, we have heard repeatedly, and I've talked to my colleagues about this, about stonewalling on paying claims. I was struck during the pandemic that even leading health institutions, like our own Oregon Health and Science University, couldn't get mental health claims paid by the insurance companies. At first, the insurance companies just waltzed them around and said, oh, we're having problems hiring staff and people won't come to work. But then I wrote a letter calling for a GAO inquiry into the stonewalling. And what do you know? The floodgates opened up and a gusher of money was sent to Oregon Health and Sciences Center for these claims. It should not take a United States senator weighing in to get paid for mental health care in America. These 4 barriers make a mockery out of the parity that Senators Wellstone and Domenici. And as we know, those two didn't agree on everything, but they sure thought that we ought to do right by mental health patients, and that was what the parity law is about. Tools like Pediatric, which is now run by an organization headed by former Surgeon General David Satcher and former Congressman Patrick Kennedy, are out there working to hold states and federal regulators accountable for enforcing parity law. It's going to take a lot of work in Congress at the grassroots level to address these issues. But I want to say, as we've touched on here today, we've got working groups. Senator Crapo has been meeting me more than halfway to try to deal with this. And this committee is going to work until we get these problems fixed. Now, I'll wrap up with the second challenge and then go to my friend, Senator Crapo. What we want to do is bring mental health and physical health closer together. Mental health shouldn't be fenced off from the rest of the healthcare system. That lack of integration, which I guess is the technical term practitioners use, also can be fatal. People typically start with a primary care doctor, but less than half of patients who receive a referral to a mental health care provider are able to get the care they need. The approach is often too slow to help somebody really get through a crisis. As many as 1 in 3 people who have died by suicide saw their primary care doctor within a month of their passing. Let's be clear. We're not talking about any kind of blame game on primary care docs. They're trying to do their best in a difficult time, see dozens of patients every day. The truth is, patients need more options. What's needed and what we've been talking about on our committee, and again, I appreciate Senator Crapo having these conversations with me, is we need a fresh strategy so we get primary care and mental health care for as many people as possible at almost the same time. That is really the lodestar. Let's end the interminable delays that slow down badly needed care. Taking care integration beyond the doctor's office is another priority. I'm very proud that in my home state, we've come up with something called CAHOOTS, and we got it into law, got it placed in Medicaid, where for the first time, mental health folks and law enforcement are teaming up on some of these very difficult situations on the streets. The mental health people like it. The law enforcement people like it. I think it's the wave of the future. A lot of work to do. The committee is focused on guaranteeing that Americans can get the mental health care they need when they need it. Thank all of our witnesses. I think it's going to be a particularly important hearing. I also want to thank Senator Cornyn. I understand you've worked with one of your Texas folks to have them come on up. And if you'd like to introduce them at some point, we can do that. Senator Crapo.
Thank you, Mr. Chairman, and I appreciate our partnership on this. We got a strong record of bipartisan solutions on big deals, and this is another one of those, and I appreciate that. Thank you. And thank you to our witnesses, some of whom have come across the country to testify before the committee today. We've heard from providers across the continuum of care, government officials, and policy experts who've shared a range of thoughtful perspectives and recommendations. This is the 4th mental health hearing that this committee has held this Congress. Despite diverse viewpoints on some policy questions, all have agreed on the profound importance of ensuring all Americans have access to high-quality mental health care services. Our country has experienced a challenging couple years. Even as hospitalizations and deaths caused by COVID-19 continue to decline and stabilize in the United States, hopefully permanently, the pandemic will have lasting impacts on the nation's mental health. Lockdowns, school closures, and other government restrictions led to social isolation, new and worsened cases of depression, and widespread anxiety. For many, the pandemic also resulted in tragic personal losses, worsening these and other mental health conditions. I've also heard from healthcare providers across Idaho where the stress and uncertainty of the pandemic have further exacerbated professional burnout. Onerous regulatory burdens have caused many physicians and allied health professionals to retire early or to reduce their hours. The resulting workforce shortage makes it more challenging for patients to access the mental health services they need. Studies have found that the prevalence of mental health illness is similar between rural and urban areas. But individuals living in rural and frontier areas often face significant barriers in accessing needed mental health services closer to home. On average, rural residents have to travel further and receive services, and providers are less likely to practice in these communities. While the pandemic has increased the pervasiveness of mental health concerns, it also has led to innovative solutions that address these challenges much better than we were in the past, such as the expansion of telehealth services. Telehealth expands access in underserved rural areas, improves care coordination and integration, and provides more privacy to patients to combat stigma. While there is no easy solution, I'm committed to working alongside my colleagues to tackle these challenges in a bipartisan and fiscally responsible way. We cannot simply throw more money at the problem and expect to solve everything. Instead, we must focus on developing data-driven, innovative, and creative solutions to address these challenges. I look forward to hearing from today's panel on their ideas to ensure that Americans in need can access timely, high-quality mental health care services. Thank you all for being here again.
Thank you, Senator Crapo, and we'll go on to the member introductions in just a minute. I want to touch on what Senator Crapo talked about. He and I have teamed up often over the years, whether it's forestry, transportation, healthcare issues, and I think it would be fair to say the two of us think this is one of the most important challenges that we've dealt with, because this was a challenge, folks, before the pandemic. It was over here. After the pandemic, it's up here. So you got a group of senators, Democrats and Republicans, who are all in on this. One other quick point, and that is Senator Crapo made mention of the telemedicine piece. And one of the best parts of the budget that passed, and it was led by this committee, was to make sure that we could get audio-only telemedicine. And my colleagues, remember, we all sat here, and the practitioners said, hey, we love broadband. Get it going, make it happen. But until you do it, get audio only. And audio only, particularly for seniors, folks in rural areas. So Senator Crapo and I really dug in for audio only coming out of our hearings, and I want to thank him for that. Okay, on to introductions. John Dicken of the Governmental Accountability Office. They've done a lot of work with us over the years. I believe I am one of the largest partakers of GAO work. If you were to add all of the characters up in the Congress, he does a good job on the healthcare markets, public health issues, private markets. We appreciate it. He's been at GAO since 1991, master's degree in public administration from Columbia University. Now I would like to let Senator Cornyn introduce Dr. Andy Keller, and then we will have Senator Cantwell introduce Dr. Anna Ratzliff. Senator Cornyn.
Thank you, Mr. Chairman. It's my pleasure to introduce our next witness, or one of our witnesses, Dr. Andy Keller. Dr. Keller is president and CEO of the Meadows Mental Health Policy Initiative, a Texas-based nonprofit dedicated to improving mental health care delivery in Texas and across the nation. He's a licensed psychologist with more than 20 years of experience in behavioral health policy, financing, and best practices. His work is centered on helping communities implement evidence-based and innovative care and develop the regulatory and financial frameworks to support them. Dr. Keller and the Meadows Institute have been leaders in the establishment of innovative programs that I hope will be emulated across the country. In June of last year, the Meadows Institute Lone Star Depression Challenge was named the recipient of the $10 million Lone Star Prize. This challenge, in partnership with the Center for Depression Research and Clinical Care at UT Southwestern, will catalyze an unprecedented statewide and national effort to put depression care in Texas on par with care for heart disease and cancer. The Meadows Institute also helped lead the development of Right Care in Dallas, which uses a multidisciplinary response team to reshape behavioral health crisis response in the city and divert people who are suffering mental health crises who happen to commit crimes or encounter the police so that they can get the care and treatment that they need to recover and get better. I was glad to be joined by Meadows Institute last month to discuss the incredible work Dallas is accomplishing because of its collaboration with Right Care. Dr. Keller is a wealth of knowledge and a steadfast advocate for innovative mental health policies. I'm sure we have a lot to learn from his testimonies. So Dr. Keller, welcome here. Thank you for your service to Texas and the nation, and it's a pleasure to have you here today. Thank you, Mr. Chairman.
Thank you, Senator Cornyn and Senator Cantwell.
Thank you, Chairman Wyden, and thank you to you and Ranking Member Crapo for holding this important hearing, and I really do appreciate the collaboration between the two of you. I want to take a moment to introduce Dr. Anna Ratzliff, who's from the state of Washington, who's been a pioneer in improving mental health care system. Dr. Ratzliff is a psychiatrist and professor at the University of Washington Department of Psychiatric and Behavioral Sciences. She served as a psychiatric consultant delivering behavioral health care in primary care settings in Washington State. And she's a national expert on the collaborative care model that helps medical teams improve and coordinate and integrate care. Can't tell you how important this work is. She has also served in several national and international leadership positions that helped clinics implement the collaborative care model. She has additional expertise in suicide prevention, training mental health workforce, including serving as the director of UW's Psychiatric Resident Training Program and director of the University of Washington Integrated Care Training Program. She is a member of the American Psychiatric Association, has partnered closely with APA to disseminate and promote improved access to care through integrated care, to advocate for policies that would support deployment of the collaborative care model more broadly. Dr. Ratzliff, thank you so much for being here today. Thank you for taking time to talk about this innovative model. I think you'll find the members here, at least present, including Senator Stabenow, to be very up on these issues and just very anxious to understand how we as a nation really, if you ask me, I served 6 years in our state legislature on the healthcare committee, and everything was, did it improve the quality of care? Did it help us lower costs? And did it, deliver more transparency in the system? And we usually voted for the things that did all three. This is exactly what collaborative care does, and that's why it's so important. So thank you, Mr. Chairman. Thank you for holding this hearing, and welcome.
Thank you, Senator Cantwell. And Dr. Ratzliff, we're going to have the Northwest collaboration action between Washington and Oregon, because we so appreciate your leadership. And just so the record notes, as Senator Cantwell touched on, the American Psychiatric Association, of course, has been at the forefront of developing these integrated care models. They recommended to us, colleagues, Dr. Ratzliff, so we're glad that that is happening. And Mr. Reggie Williams is here. He leads the Commonwealth Fund's program on international health policy and practice innovations. They focus on behavioral health, as you know. Senator Stabenow has been our leader on all things relating to behavioral health, so we're glad you're here to focus on that. Prior to his work at the Commonwealth Fund, Mr. Williams worked for 15 years as a managing director at Avalier, focused on evidence-based medicine policy, digital health, all things we care about greatly. He's chair of the board of directors of Mental Health America, an important nonprofit. Got his bachelor's degree in biomedical ethics from Brown University. Okay, let's get on with our witnesses, and let's start with you, Mr. Dicken.
Thank you, Chairman Wyden, Ranking Member Crapo, and members of the committee. I'm pleased to be here today to discuss GAO's new report released today, titled Mental Health Care, Access Challenges for Covered Consumers and Relevant Federal Actions. This is the most recent in a series of GAO reports examining ways that the pandemic has affected behavioral health care and examining state and federal oversight of behavioral health care parity. In 2020, 53 million Americans in the United States, which is 1 in 5 adults, had any mental illness. This includes an estimated 14 million people that had serious mental illness. The COVID-19 pandemic and related economic crisis have intensified concerns that even more people are affected by mental health conditions, and that people with underlying mental health conditions could be experiencing increased severity of those conditions. Further, the pandemic has highlighted longstanding concerns about the accessibility of healthcare services, even for those with healthcare coverage. The bottom line of today's report is that health coverage does not guarantee access to mental health care services. Based on interviews with 29 stakeholder organizations and a review of research, GAO found that consumers experience challenges finding mental health care providers in their health plans networks. For example, providers who are listed as in-network may not be accepting new patients, may have long wait times, or do not provide the specific service a patient is seeking. In some cases, they actually may not be in the plan's network at all. Challenges like these could cause consumers to face higher healthcare costs, delays in receiving care, or difficulties in finding a provider close to home. GAO found that factors contributing to these challenges included low reimbursement rates for mental health services and inaccurate or out-of-date information on provider networks. GAO also found that consumers experience challenges with restrictive health plan approval processes and plan coverage limitations, both of which can limit their ability to access services. Many of the stakeholder organizations interviewed and research reviewed noted that the process for getting approval for mental health services can be more restrictive than it is for other medical services. For example, representatives from one health system report that some health plans are less likely to grant prior authorization for mental health hospital stays compared with medical and surgical hospital stays. Some stakeholders also noted various coverage limitations and restrictions that limit consumers' access to certain mental health care treatments or limiting the types of providers eligible for payment. These include certain statutory restrictions on the types of mental health care providers eligible for reimbursement under Medicare. Let me conclude by briefly noting some of the federal efforts that may address some aspects of the challenges that consumers experience attempting to access mental health care. The Departments of Labor and Health and Human Services are taking steps to improve access to mental health providers, including steps to enforce requirements for certain health plans to update and maintain provider directories. The Substance Abuse and Mental Health Services Administration within HHS is managing several programs aimed at addressing structural issues that contribute to a lack of capacity in the mental health care system. This includes grant programs to increase access to community-based mental health care. And the Health Resources and Services Administration within HHS is managing several programs that provide funding intended to increase the mental health workforce. Finally, there are federal efforts focused on issues with health plan administrative approval processes. The Departments of Labor and HHS are taking steps to enhance their oversight of the use of non-quantitative treatment limits by health plans, such as requirements for prior authorization. This is part of their broader responsibility to oversee compliance with mental health parity laws. These laws generally require that coverage of mental health treatment be no more restrictive than coverage for medical or surgical treatment. This concludes my prepared statement, and be pleased to respond to any questions the committee may have.
Thank you very much, Mr. Dicken. Dr. Keller.
And thank you for your leadership on these issues, including the excellent work of the committee, gathering feedback from across the country and putting actionable policy ideas that you summarized in the report that was just released by the committee. My name is Andy Keller. I lead the Meadows Mental Health Policy Institute, and we're dedicated to helping Texas and the country move forward availability and the quality of evidence-driven mental health and substance use care. I want to thank you also for setting aside this hearing to focus specifically on the harms caused by the dramatic lack of parity today in mental health and substance use disorder benefits across the country, and for bringing us together to look at solutions. As I described in more detail in my written testimony, we all need to come together. It's going to take providers, health purchasers, insurers, regulators, and people and families affected by mental illness and addiction to address these issues, but we also need action by the federal government. It's essential for creating the infrastructure nationally that we need to move out of this decades-long quagmire. And Chair Wyden, you described well that our behavioral health today is worse than it's ever been, and the pandemic made it worse. Suicide is currently the fourth leading cause of lost life years. Overdose deaths claim even more people and increased by almost a third during the pandemic. Late last year, the Surgeon General offered an unprecedented first-ever public health advisory focused on the mental health of the nation's youth, and these consequences fall hardest on Black, Indigenous, and Hispanic and other people of color who too often receive inequitable and less culturally responsive care. There's really two reasons why we're in this mess. First, we have dramatically cut spending on behavioral health over the last 40 years. The cuts started in the 90s, and today we spend 20% less compared to the rest of healthcare on mental health than we did before these cuts and these aggressive mechanisms that Mr. Dickens described quite well were put into place. The other reason is that we have failed until recently to begin to actually enforce those parity laws that 5 successive presidential administrations put into place, dating back to the Clinton administration. And continued enforcement is essential. Just to give you a couple of the outcomes of the impact of the non-quantitative treatment limitations, which is a mouthful, but it's an important thing for us to focus on, that Mr. Dickens described. Commercially insured people are 5 to 6 times more likely to use out-of-network care because of the limitations that were just described. And when we look at reimbursements, it's not hard to see why. Reimbursements for mental health are consistently 20% lower than benchmark reimbursements for other specialties and for primary care. And these barriers have to be addressed by all of us coming together. It's not going to be enough just to have regulatory enforcement. We're also going to need to increase the kind of infrastructure to promote primary care-based interventions like collaborative care. I want to just focus on 3 solutions. There's more detail on these in my written testimony. The first is that enforcement does need to continue. Laws are not enough. We could have a speed limit, but unless it's being enforced, people are not going to obey it. And that's only been going on really in earnest since late last year. It's going to also require more effort there, additional funds to expand the breadth of those efforts. We also like the Department of Labor to be vested with the authority to assess civil monetary penalties for parity violations. And we would also like to see ERISA amended to provide the DOL with authority to directly pursue parity violations by entities that provide administrative services to ERISA group health plans. That sort of expanded enforcement needs to continue and it needs to be broadened. The second thing is the parity protection should be extended to Medicare beneficiaries. The data suggests that the failures of commercial plans apply as much or more so to Medicaid beneficiaries, especially the lack of available providers. And there are also numerous gaps in the Medicare mental health and addiction benefits that are not faced by people with commercial coverage or with Medicaid in most states. But the most important thing that Congress can do would be to launch an emergency initiative to bolster the capacity of primary care to effectively serve more Americans and relieve the pressure on specialty networks. Integration works, and it is really our only path forward. While insurers do need to do more, they cannot on their own, no matter how much we regulate and enforce, fix a misdesigned health system. Today, we fail to detect and treat needs until 8 to 10 years after they emerge. The collaborative care model, which was described, can leverage the availability of psychiatrists 3.5 times over. The primary care behavioral health model can leverage other licensed practitioners 2.5 times over. Both are currently covered by Medicare, almost all commercial payers, and most Medicaid plans. But no single payer can do this. It's going to take an infrastructure investment. The RAND Corporation has laid out a study last year that showed how to do this. There is existing legislation filed by the House by Representatives Fletcher and Herrera-Butler that could form the basis for this. It's legislation that every medical association supports. It would need to be broadened to include primary care behavioral health and expanded many times over, probably in the hundreds of millions of dollars to have the breadth needed. We're doing this in Texas now, $20 million put up to get 1/3 of the state through those reforms. This will be the standard of care in 20 years, but if we wait that long, we're going to lose 2 million more Americans to suicide and overdose. Thank you for the opportunity to be here today.
Dr. Keller, you may not have seen it, but when you mentioned expanding coverage for Medicare folks, everybody was nodding their Adam's apple off. So thank you for that and for your leadership. Dr. Ratzliff.
Thank you, Chairman Wyden, Ranking Member Crapo, and thank you to the committee for conducting this hearing today. My name is Dr. Anna Ratzliff. I'm a psychiatrist and professor at the Department of Psychiatry and Behavioral Sciences at the University of Washington. I have personal experience as a provider delivering integrated care, and I'm the co-director of the AIMS Center, which has implemented a model of integrated care, which has been talked about today, the collaborative care model. As a member of the American Psychiatric Association, I've partnered closely with the APA to promote this model through policy and advocacy. Effective integrated care is an important solution to our current healthcare crisis, as everyone is talking about. The collaborative care model is a specific model of integrated care developed at the University of Washington to treat common mental health conditions such as depression and anxiety in primary care settings. This model is evidence-based, with over 90 validated studies showing its effectiveness, and has been recognized by the Centers for Medicare and Medicaid Services with specific billing codes that were introduced in 2017. I believe the power of integrated behavioral health care, and specifically the collaborative care model, is best illustrated through patient voice. Daniel was one of my patients who has given me permission to share his story. Daniel was a young adult who had been struggling with untreated mental health conditions since he was an adolescent, and these eventually led to a suicide attempt. He finally sought treatment through his primary care provider, and on his first visit, she recognized that he was struggling with mental health symptoms and connected him that day to a behavioral health care manager whose office was just down the hall. Daniel was able to walk with his PCP to meet this behavioral health provider and later schedule an intake appointment within the same week. As a psychiatric consultant, I was able to review his case within a few days and during my regular meeting with my behavioral health care manager. My consultation was done using telepsychiatry since my office wasn't located in that primary care setting. And this approach allowed me to review multiple patients in the clinic at a time that it would normally take me to only see one patient. Although I didn't see Daniel in person, we were able to determine his diagnosis, and I provided recommendations to his around medications to be prescribed by his primary care provider and for behavioral interventions to be delivered by his behavioral health care manager right there in primary care where he was comfortable being able to get care. Within weeks, he was feeling better, and he enrolled in a local community college. He eventually was able to successfully complete his training and become a medical assistant. This example is important because Daniel said that he never would have sought mental health care if it hadn't been so seamlessly available in his primary care setting. And his mother feels that this access saved his life. As you can see from this patient's experience, integrated care has several important features. Patients can receive care without the need for referrals, which frequently can take months and often results in patients not being able to receive any care. More widespread use of the collaborative care model can help alleviate some of the portion of the mental health workforce shortage that was mentioned in the preceding testimony. As a team-based approach, this model leverages expertise like mine as a psychiatric consultant to support 60 to 80 patients in as little as 1 to 2 hours a week. Integrated care allows for the early diagnosis and intervention of mental health conditions and has proven to reduce suicidal ideation and prevent emergency room visits and hospitalization. Additionally, this model has demonstrated effectiveness in addressing behavioral health needs of special populations. This model has been able to be delivered in rural settings, often using telehealth to bring psychiatric expertise to these communities. The collaborative care model is also an important strategy to improve behavioral health equity. Studies that compare depression outcomes in BIPOC and white patients who receive treatment with the collaborative care model show either equivalent or significantly better outcomes for the BIPOC patients. Finally, expanding the use of the collaborative care model can also help reduce healthcare costs. Studies have demonstrated for every dollar spent on collaborative care model, about $6.50 in total healthcare costs are saved in the subsequent years. Although the implementation of the collaborative care model makes sense, the requisite startup costs have proven to be a barrier to its adoption by primary care practices. I encourage the committee to consider the following policy recommendations endorsed by the APA to further the adoption of the collaborative care model. Fund primary care offices to assist with the implementation of the collaborative care model. Eliminate the cost-sharing requirement under Medicare to remove an additional barrier for patients and Medicare beneficiaries. Increase the current reimbursement for CPT codes for the collaborative care model to more appropriately reflect the value and benefits of services and care being provided. In closing, I want to reiterate how encouraged I am by the bipartisan, bicameral support we've seen from Congress, and in particular this committee, regarding addressing our most pressing mental health and substance use disorder needs. Thank you.
Thank you very much. We're going to look forward to working with you. Mr. Williams.
Good morning. Thank you, members of the Senate Finance Committee, for inviting me to speak. Chairman Wyden, Ranking Member Crapo, you have both been leaders on this pressing issue. Your bipartisan commitment will advance solutions for people in need. I am Reggie Williams, and I lead the international program at the Commonwealth Fund. I also co-lead our work on behavioral health. For over 10 years, I have volunteered my time in the mental health community, currently serving on the boards of the Youth Mental Health Project and Fountain House. In the past, I chaired the board of Mental Health America. My focus has been on improving systems that people and their families must navigate to achieve the lives they want to live. I testify today not only as someone who has spent 20 years in health policy, but also as a Black man who strives to manage his own mental health. We all know there's a behavioral health crisis in the United States. The crisis is nationwide without regard for political affiliation, class, or education. It's particularly acute for economically disadvantaged and historically excluded communities. At the core of the crisis is unmet need. There have been incredible strides with the Affordable Care Act, but yesterday's Senate Finance Committee bipartisan report, the GAO report, definitively detailed unmet needs and barriers, especially for Black and Latino people, youth, and Medicare and Medicaid beneficiaries. The problem is big and complex. However, I believe we have the tools to make meaningful change in people's lives. There are 3 things that we can do. First, integrate mental health and substance use care with primary care. 2, expand and diversify the behavioral health workforce. And 3, leverage the potential of health technology. Integration. Expanding the capacity of primary care providers through integration increases access. Studies show that patients view primary care providers as trusted sources of information. That can combat stigma. Integration offers a solution that includes everything from consultation, co-location, to patient-centered shared decision-making goals. It is also helpful to think of this integration across a broad continuum. Innovative payment approaches can continue to support integration through new fee-for-service billing codes, care management payments, bundled payments, and primary care capitation. As policymakers contemplate ways to support CMS in the states, there are many promising models to consider. As I stated in my written testimony, the Southwest Montana Community Health Center, a federally qualified health center in Butte, Montana, links people to counseling and community programs and has demonstrated substantial reductions in substance use. Another is addressing social isolation through psychosocial rehab, as Fountain House does by connecting people with serious mental illness to primary care, psychiatric care, and home and community-based services. This approach has reduced hospitalizations and decreased costs for Medicaid. Expand and diversify the workforce. The evidence supports including a wider array of providers and behavioral health care teams. Trained and accredited peer support specialists leverage their lived experience to engage people and reduce substance use in the use of hospitals and emergency rooms. Community health workers have demonstrated that for every dollar invested in a community health worker, they return nearly $2.50. Further, engaging peers and community health workers who are representative of the communities in which they live can be an important way to address stigma. Another example has been seen in the introduction of new types of providers, like the general practice mental health worker. They have been successful in the Netherlands, where they have been integrated into primary care and have prevented exacerbations of mental health. Despite improved outcomes and cost savings, most Americans did not have access to the providers I mentioned. To remedy that, there's an opportunity to implement financial incentives, support efforts to recruit and retain, implement learning collaboratives and quality improvement initiatives, and ensure insurance coverage for a broader workforce, including peers in the Medicare program. Leveraging health technology. During the pandemic, the use of telephone and online platforms skyrocketed. In addition, digital health tools have received unprecedented investment and can help solve the provider shortage. On the other hand, we don't want to champion the use of tools that are ineffective or inaccessible for beneficiaries, especially for people facing the greatest barriers, such as rural Americans or people with disabilities. It is critical that the expansion of health technologies be undertaken with universal and equitable access in mind. As Congress and the Biden administration weigh options for extending telehealth flexibilities, it will be essential to ameliorate rather than exacerbate these disparities. It is also noteworthy that the temporary continuous coverage requirement that kept Medicaid coverage intact during the public health emergency helped to ensure access to these types of services. In conclusion, as I stated, the problem is big and complex, but we have the tools to improve lives, especially for youth, people with serious mental illness, those in rural communities, and historically excluded Black and Latino indigenous communities. In the coming months, we can work together to implement bipartisan policies to expand access to equitable and affordable care. Our communities will be stronger for it, and I believe we can be better. Thank you.
Mr. Williams, thank you. And thank you all for very valuable testimony. Let me start with you, Mr. Dicken, and I very much appreciate your helping our investigators work through this bizarre array of ghost network practices that are just flagrant ripoffs, in my view. And I wanted to ask you about one instance, you basically, working with these various studies, found that in 83% of the instances, this was in your report, families would try to get an appointment for a child and adolescent psychiatrist, and they couldn't get one. So my first question to you is that sort of thing common?
Yeah, thank you, Chairman Wyden. And you're right that we did find multiple studies and heard from many stakeholders concerns about those provider directories not being accurate, calling them, in some cases, ghost networks. And so we heard across whether it's Medicaid plans, private insurance plans, Medicare Advantage plans, in multiple cities, problems that many providers listed in a directory would not be available for new patients or not available at all.
Very good. We'll also say for shorthand it's common because it's clear that's what you said. All right. Dr. Ratzliff, ghost networks. Have you seen these kinds of practices, Dr. Ratzliff?
Yes, I've unfortunately had patients that needed to seek care and would go to their provider directory, call sometimes 30 or 40 providers, and either be told that there was no access, no availability, be put on wait lists, or just never hear a response. And this often resulted in people not being able to access the care that they needed.
So you would call, in these kinds of instances, something like this: nothing resembling parity.
Nothing resembling parity. You could go out and get a primary care provider in those practices, but in those insurance panels, but not access mental health care.
All right, Dr. Keller, why is this happening? What's the problem? Because I personally think this is making a mockery out of the parity law, based on what we just heard from Mr. Dicken and Dr. Ratzliff. Why is it happening?
It's happening for two reasons. One, we're not paying on par. I mean, the studies clearly show that the insurers are paying 20% less in reimbursement compared to other specialty care and primary care. So they're not paying enough, and that's why people who want to pay cash, who will pay more, are somehow magically able to get people. The second thing is the administrative hassle. I mean, the thing that those NQ2, the non-quantitative treatment limitations do, is they make it a hassle. And that's the other reason why people only take cash, is they don't want to have to fill out all that paperwork. They don't want to have to have people call multiple times to get authorizations. They don't want to be harassed. So the administrative burden and the lack of, I mean, it's not rocket science. It's two things that are driving this down.
But isn't part of it that nobody is holding these giant insurance companies accountable? Because I think you heard me describe the situation at Oregon Health and Science University. I go up there regularly, as we all do, to talk to our universities and talk to the practitioners, and they basically said they couldn't get any claims paid. And I said, I bet some of it has to do with the challenge during the pandemic. Folks were worried about COVID, and you couldn't get workers, and folks would leave for other fields. And we all kind of thought about it. And I said, I'm going to open this GAO inquiry, which Mr. Dicken knows is, what has led this effort this morning. And after there was a small newspaper story, this was not like headlines, everywhere, a small newspaper story saying we're going to have an investigation here into whether the parity law is really being complied with. OHSU got a gusher of payments. I mean, within a matter of weeks. And you don't know really whether to laugh or cry, because we're glad that folks got reimbursed, but we can't say that every single senator in this body is going to suddenly take the place of enforcers. We've got to get these insurers and these agencies and people who are supposed to carry out this law to get off the dime and get serious about this. Because as far as I can tell, these big insurance companies are just muscling everybody around with their excuses and this parade of reasons why they shouldn't have to comply with a law that is 13 years old. In fact, I heard one statement from one of them saying, well, we're still working through what the law is about. What a bunch of baloney. After 13 years, and Senator Wellstone and Senator Domenici had a good law, My brother was a schizophrenic. We saw for years and years. The Wyden family would go to bed at night worrying about whether my brother was going to hurt himself or somebody else. And when he passed, and the law of Senator Wellstone and Senator Domenici, I said, this is going to be a new day for everybody else, every other family that's dealing with these issues. And we're in the same position today because of these insurance companies muscling everybody around and figuring out excuses for not complying with parity. So we're going to get to the bottom of it. You all have been great. My friend, Senator Crapo.
Thank you, Mr. Chairman, and to you and to our witnesses. I have to step out for a quick meeting, so I only have a chance for one quick question here, and I think I'll choose you, Dr. Keller. I could ask this to any of you, but we've heard a lot of discussion today about the collaborative care model. Could you just describe in a little more detail, get down in the weeds a little bit, what is the collaborative care model and how does it work?
I'm happy to, though, but so the collaborative care model basically puts a behavioral health care manager in the primary care practice. So it's a person to help the primary care doctor be able to carry out the additional procedures that are necessary to assess, diagnose, and treat mental health and addiction disorders within primary care. So it's just like the doctor now has a nurse, and he can go and take your blood pressure, and he can take your temperature, and that helps the doctor out so she can do her part. The behavioral health care manager basically extends the ability of the primary care provider to do those in-office concerns, and it works just as well with virtual presence through telehealth as it does through in-person. And then there's also a psychiatric consultant to help with medication questions. And that psychiatric consultant reviews what's going on, is there to help support the primary care doctor, so the primary care doctor can treat upwards of 70% of mental health conditions can be treated successfully with the same or better outcomes than specialty care in primary care with those two supports. And then the other thing is they have special data systems to track people, because what happens is if you have depression, sometimes you don't take your meds, sometimes you don't come back to your appointment, and someone needs to make sure you don't fall through the cracks. And so the registry and the tracking system the care manager uses to make sure the person does not fall through the cracks.
So this obviously involves additional providers and additional staff in a traditional doctor's office, if you will, correct?
I would say, sir, that Senator, it's a redeployment of staff into them. We don't need more people to do this. We need them redeployed into primary care settings.
All right, and so does this mean, though, that there is a need for us to change either the mandates or the incentives or what have you in the insurance markets? Or does it mean, and I think Dr. Ratzliff talked to this, that we need to change the reimbursement policies in Medicare and in other government-run healthcare systems? Is that piece of it, the finance side of it, something that we need to be able to tool up?
There could be some tweaks to that, but basically once it's up and running, payment mechanisms in commercial care and Medicare and most Medicaid plans currently cover it somewhat adequately. But what they don't cover are the startup costs, and they don't cover the technical assistance needed to convert a practice quickly. So it's really getting over that hump of startup that we require additional investments.
Well, thank you. I'm going to have to run. I'll be right back soon, Mr. Chairman.
Thank you, Senator Crapo. We're going to be working on all of this together. Senator Stabenow is next.
Well, thank you so much, Chairman Wyden and Ranking Member Crapo. It's a very exciting time for those of us who've worked a long time on mental health issues to see the focus on this committee. Thank you so much. And to frankly see the focus in President Biden's budget, which is the strongest focus on investments in mental health and addiction, I think, ever. And so that's very exciting as well. And I did want to say, as the person who was honored to offer the amendment to the Affordable Care Act to implement the Wellstone-Domenici parity, mental health parity language, it's shocking to me to see that we still don't have this after all of this time. But I want to thank all the witnesses. You've done a great job explaining why integrated behavioral health care is so very important. And I think for us, we have to make it clear that integrated healthcare is much more than a buzzword on the name of a new payment model. It really is a system-wide transformation that we need to make it happen. It requires funding community behavioral health care the same way we fund physical health care in the community. For far too long, behavioral health care has been funded through grants, and inadequate reimbursements where providers are paid for an individual service, but not for the broader range of services that address the patient's full range of needs, like community health centers are reimbursed for. So the good news is this is changing, and I want to again commend President Biden for including in his budget for the first time an extension across the country to all states for our bipartisan evidence-based certified community behavioral health clinics. And these clinics see everyone that walks in the door. They're open 24/7, 365 days a year, which is so important. Mobile crisis stabilization, check-in visits with peer support specialists, treating mental health and substance abuse, working with hospitals, primary care, veterans groups, everybody in the community. So what we need to do is make sure we are fully moving forward on this model. So Dr. Keller, I know Texas has nearly 40 certified community behavioral health clinics. Can you talk about the role of these clinics in improving access to behavioral health care in Texas? How's the model working in your state? And then what would it mean to Texas to be able to fully participate in the fully funded program that Senator Blunt and I have been leading, but so many members of our committee, including your own senator from Texas, is co-sponsor of. So.
Well, thank you, Senator Stabenow, and thank you for your leadership on this and for the Congress's leadership, because it is a critical model. In fact, it's so effective and so important that we have moved it forward with 38 of our 39 community centers in Texas, despite not being one of the 8 states that had this sort of easier path to do that. And we've put it together with sort of so it's super effective. And I mean, just think about it. A lot of times our community behavioral health centers are really the only provider in a region in our rural areas. So not only are they a bulwark for the service to people with severe mental illness, with addiction, but to folks with lesser concerns in the community. And it's very important that that be undergirded. I mean, the real challenge we have is funding. And we've been able to do that through a hodgepodge, through our 1115 waiver, with some interesting negotiations with CMS, and with the grant programs that were extended under the pandemic were very helpful. But that sort of funding is insecure. It's a constant battle to figure out how do we continue to do this, and the type of direct federal funding that FQHCs currently have is what we need. And it really is, I believe, Senator, a parity issue, that we need to put these behavioral health treatments on par. I think we saw during the pandemic how hard it was to get funding out. You and Senator Cornyn had to team up to get those funds out during the Provider Relief Fund days to behavioral health providers, because there aren't those direct paths. And that patchwork of funding is a barrier at multiple levels, but the model itself is extremely effective, including by bringing addiction treatment into the integration, which is essential.
Well, thank you. And it really is, if we want full parity, we have to have parity in reimbursement. We have to have parity in funding, and that's what this does. It says the wonderfully successful federally qualified health centers model that everyone supports, strong bipartisan support, is now going to be applied on the mental health and addiction side. And in so many places, I know in Michigan for sure, they're located at the same place. They are fully integrated, which I think really is the goal for us, to be able to serve people in the community. Let me speak just a little bit more. We've heard from all of you about the fact that many private health plans still not providing, of course, mental health parity, not moving forward on this. I strongly support the administration's efforts to crack down on this. We need to do more. We need to enforce the laws on the books so that Americans can get the care they need. But I think we also have to do more. You've talked about Medicare, which is very important. I know is also included in the president's budget. To include making sure that Medicare beneficiaries have access, they have to have the best type of providers as well, which goes to the question of workforce, and that's an area that Senator Daines and I are working on in this committee. So we have bipartisan bills. I have a bipartisan bill with Senator Barrasso to add licensed professional counselors and therapists to the Medicare program and increase access to licensed clinical social workers, for example. Also, I'm very supportive of Senator Cortez Masto and Senator Cornyn's work to expand access to peer support specialists. So Mr. Williams, could you talk about the importance of counselors, peer support specialists, clinical social workers in the mental health workforce area, and why strong workforce can help us achieve real parity?
This will be the last question on this round. It's a very important one. We just have 20 members all waiting to ask questions. Mr. Williams, respond, if you would, to Senator Stabenow.
Thank you, Senator, for that question. Peer support specialists and community health workers are vital resources to expand the workforce. As we've discussed, the need is quite wide, and these individuals and professionals that our peers, our community health workers, can expand the availability of resources and supports. We see that in places where you can't have someone necessarily co-located or integrated in a full model that can be intensive, that just having one or two additional people that a physician can turn to refer an individual to get services can be very important. Our data show that those individuals who are delivering those services actually meet people's needs in a wide variety of ways by being individuals that can be concordant with their needs, they understand the experience that they've had, and they can then refer them to services to get them out of the situations that they're in. And so when we think about the expansion of the workforce, adding things like care management payments, bundled payments, primary care capitation are all ways in which these expanded workforce individuals can be paid and reimbursed in our current system.
Very, very important, and I strongly support Senator Stabenow's work on this critical issue. Our next members, and we'll see who's online and who's here, would be Senator Grassley, Senator Cantwell, and Senator Cornyn. Senator Grassley, are you online? Senator Cantwell. Senator Cornyn's here. We welcome him. Please.
Thank you, Mr. Chairman. Dr. Keller, looking at some of the statistics with regard to self-injury and suicide among children, particularly given the terrible circumstances of the pandemic, the isolation, the anxiety over being able to put food on the table, jobs and the like, had a particularly heavy toll on our children. In the first half of 2021, children's hospitals reported cases of self-injury and suicide in children ages 5 to 17 at a 45% higher rate than during the same time in 2019. I know that in Texas, 12 publicly funded medical schools have come together for the Texas Child Mental Health Care Consortium to provide telehealth services to children at school. Can you talk a little bit about the importance of leveraging technology like telehealth in order to deliver those services and the challenges we have across the economy in terms of trained workforce to be able to provide the access that we'd all like to see expanded and provided?
Certainly. Thank you, Senator, for that question. And that Texas experience, I think, has been instructive by bringing the way we brought all 12 medical schools together. And really, that's where most of our child psychiatrists and our child fellows are. So, we only have a couple hundred child psychiatrists in Texas. And being able to bring more of them together through that network was essential. And we did it through telehealth. And right now, that telehealth network is available for real-time urgent care requests in hundreds of districts across Texas, reaching over 2 million of the 5 million school-age children we have in Texas. And we were able to stand that up during the pandemic through legislative funding, and we were able to have that be statewide. And it's critical that we not just have, UT Southwestern, Baylor College of Medicine, Dell involved, but also UT Tyler and Texas Tech El Paso and Texas Tech Lubbock being able to reach out because they know their communities, and telehealth allows them to get to those schools and do those real-time urgent care visits. And we were also able to use ARPA funds allocated by the last legislature, the Texas legislature, to expand that. So now it's not just urgent care, but we're actually able to do more routine care. And it has been essential. It's essential, too, because it provides supports in primary care. And I would say that those emergency room statistics you talked about, when we talk with working very closely with Children's Health in Dallas, the priority they have put in terms of what's the best way to reduce pressure on the emergency room our primary care interventions. It's basically leveraging those primary care networks, helping them do more so that children don't end up having to get in the situation where they end up in our emergency rooms.
And of course, I mentioned the work that the Meadows Institute is doing on the Lone Star Depression Challenge. Depression is as you point out, can affect people periodically, different times. Unfortunately, we've seen, particularly among our veterans population, the self-medication, and that makes things actually worse rather than better. We know that about 60% of the people who die as a result of a gunshot are suicides. And it strikes me that untreated depression is a real public health emergency and challenge. Could you talk a little bit about the Lone Star Depression Challenge and what lessons that you've learned so far that would be helpful to inform federal policy?
Yes, Senator. Thanks for asking about that. Well, basically, what Dr. Ratzliff described, the collaborative care model, we borrowed that from our friends in Washington State, and leading philanthropists in Texas, who you know well, Dee Rose, the Meadows family, and most recently Lyda Hill, have basically put in $20 million to allow us to work in partnership with Texas medical schools to bring health systems across the state into overcoming those startup costs. I mean, basically, they're funding the startup costs that Dr. Ratzliff described. And by the end of 4 more years, we're about a year into it, and within 4 years, we're going to have a third of the state able to access collaborative care. And right now, Baylor Scott and White Health System is furthest along in that. And in the first several clinics they have that serve actually several 100,000 people a year, we've seen depression outcomes go from 15% remission to over 60% within the first year because it works. And so it's the startup costs, and that's really what Texas philanthropists have come together to do through the Lone Star Depression Challenge. And we're very appreciative.
You and Dr. Ratzliff have talked about the collaborative care model, but we've found multidisciplinary teams very helpful in other areas like law enforcement. And I mentioned the Right Care program, which Dallas has got a great model. Concern of mine has been for a long time, and I think we all share this concern, is people who are suffering a mental health crisis are a danger to themselves and the law enforcement officials who encounter them, because when 911 is called, they obviously, the police aren't always trained to de-escalate the confrontation and to make sure that the person who's in crisis is actually diverted to appropriate mental health care. Could you just briefly, because I know time is limited, comment on what you think that model is working, and is this something that we could continue to share with other parts of the country?
Yes, Senator. I think, similar to actually the CAHOOTS model that Chair Wyden talked about, by pairing paramedics and mental health professionals together, we can reach more people. The way we do it in Dallas with the MDRT model is we have them directly partner with law enforcement as well, so they can respond to any 911 call. And we now have taken that citywide, and we're seeing not only are arrests very low, less than 2% of folks actually end up in jail, and most of those folks actually had outstanding warrants, so people were looking for them. So very few people end up in jail, but also very few people end up in the hospital, because the teams use community paramedicine to be able to provide follow-up care, make sure people get to their appointments, and get the care they need. So it's basically taking a community paramedicine model to mental health folks with mental health needs.
Thank you, Mr. Chairman.
Thank you, Senator Cornyn. Thank you again for your help in this whole kind of effort. What is important about CAHOOTS, and I'll just be very brief, is this is a chance to bring mental health folks and law enforcement folks together. You know, what we did as we started it in Oregon is said, look, the big challenge here is to make sure that the professionals in these fields are able to do what they were trained to do. That's what I heard consistently from mental health folks and law enforcement people. Obviously, if there is violence, taking place, you need to make the community get an added measure of safety. There's a law enforcement role in that. What we know, which you all have told us, is so many of the instances on the streets are mental health issues. And what's striking, and I want to commend my colleagues, Senator Booker has been very interested in this idea from the very beginning, and Senator Scott has been very interested in this idea. So I think we've got a chance to bring together something of a coalition around these issues. That's what we're going to try to do on mental health more broadly in this committee, but I appreciate you're bringing up cahoots, and for Senator Cornyn having you up here. Senator Grassley, I think you're next in line based on arrival.
Yeah, I've got a long lead-in for a question for Dr. Ratzliff and Mr. Keller. 3 years ago, Bennett and I of this committee passed the ACE Kids Act to establish a pediatric home health for kids with complex medical conditions so that dozens and dozens of specialists and doctors that have to coordinate their care, that coordination is very, very important. This October, the Centers for Medicare Services will fully implement this act. Medicaid programs will have the tools then to better coordinate rather than these families facing barriers to care and the red tape that goes with it. We know that these kids with complex medical needs are also more at risk for mental illness. One study suggested 38% have mental health diagnosis, and many face challenges accessing mental health care. Their parents are 5 times more likely to have poor mental health issues as well. So it's important that CMS implement ACE Kids Act timely, but Congress also has to follow this along with another Grassley-Bennett bill accelerating kids' access to care. It will streamline the screening and enrollment process for out-of-state kids or their providers, and I hope that this bipartisan bill would be in the committee's mental health package. The bill will improve mental health mental health of the kids with complex medical needs. So do you folks, what can the ACE Kids effort learn from the collaborative care and coordination, especially care models, especially when trying to improve mental health care for kids with complex medical needs? I'll start with Dr. Ratzliff.
Thank you, Senator, for that question. So collaborative care has shown to be an effective model for addressing adolescent depression, pediatric ADHD, and some of the other common mental health disorders. So implementing the collaborative care model in practices that serve our kids and children is a very important strategy to increase access to that effective treatment. I think also there's the opportunity, especially for children with complex needs, to be able to address all of their needs in one place, hopefully reducing the burden of their families in really trying to coordinate that care. I think many of my patients commented on the fact that they didn't have to, manage that communication between their different providers when that service was all offered together in one setting. So I think that's a really important opportunity, is to reduce that burden of the family really having to coordinate the care. And also I think it makes it easier for the providers. And we know that provider burnout is a really big challenge right now. And so anything that we can do to make that easier for the whole care team, I think, is very important.
Mr. Keller.
Well, I would just add, Dr. Ratzliff explained that well. The only thing I guess I would add is that right now it takes 8 to 10 years before we reach a child with mental health needs with effective treatment. And so by being able to broaden this to every pediatric practice, both specialty ones that deal with children who have special needs, but also every child being able to have access to this screening is essential. And it's also important around stigma, which is an issue across the board, but also for historically underserved and excluded communities, people in poverty. If you have to have somebody go back to a second appointment, we're going to have studies show 50% of people fall through the cracks just by saying, okay, we need you to go see the specialist. So by having all of that there, detecting early, those are really the things that make it work. And that is part of, I believe, the description of the bill you all are looking at, and it also is available more broadly in the collaborative care model.
A short follow-up to Dr. Ratzliff. Is telehealth for mental health any advantage or just more access but not necessarily filling in?
I think telehealth is a very important part of really creating those spectrums of healthcare access. I think it helps with a couple of things. I think the most important thing that it helps with is the redistribution of the specialty expertise. So a lot of our, as I think Dr. Keller said, a lot of the people who are child and adolescent psychiatrists work for large medical centers or live in larger cities. So especially for our rural populations or communities where they might not have a child and adolescent psychiatrist, for example, to consult, you can get that expertise through telepsychiatry, and that makes a huge difference for patients getting the kind of expertise that especially patients with complex needs often need, those experts being able to weigh in and provide recommendations. And sometimes a single visit can be enough to really get the recommendations to a primary care provider or other medical provider that can then implement that plan. And so it's also a way to, I think, leverage a scarce resource, right? So sometimes a single visit might be enough, and you don't have to actually have ongoing care as long as you're having that care coordinated by the local treating provider that family already feels comfortable with, trusts. And again, that's a big, important thing for people receiving care, because they often can receive that then from a trusted provider.
Could I have one more?
Of course, sure.
Yeah, this will be my last one. I might have some for answer in writing. And I don't know to what extent you're up on things in rural areas, and because I missed your opening statement, Dr. Ratzliff, but suicide rates among youth have risen over the last decade and generally higher in rural America. In December, Surgeon General issued an advisory on youth mental health to draw attention to this urgent issue. While the advisory indicates rural youths are more at risk, the advisor does not speak to the specific resources for rural young people. So to you, Dr. Ratzliff, given the lack of rural resources provided by the Surgeon General's advisory to improve youth mental health, what mental health resources are available for rural youth? And if you're acquainted with organizations like FFA or 4-H's or possibilities for working through those organizations?
Thank you for this question. I think there's a couple of models that people are using to try to increase access for mental health for youth. And I'll give an example from Washington State. We have something called the Pediatric consultation line that allows any primary care provider really in Washington State, any pediatrician, to actually get behavioral health consultation on patients, get support provider to provider, so that those providers that are located in rural settings can actually get that kind of support. I think the idea of community organizations, and I actually was in 4-H, so I think it's a great one to think about, that actually there's opportunities there to really think about how do we maybe make those organizations more aware of how to recognize youth at risk. And then often those communities really know their community and can connect people to care. So I think there are opportunities to think about how do we really engage our community organizations in partnering with either their local primary care providers or other services to make sure that anybody that's identified at risk can get the help they need.
Thank you, Senator Grassley. And Dr. Ratzliff, apropos of your further comments on telehealth, so you know a little bit of the history of this committee. Not only did Senator Crapo and I team up on the audio-only portion of the latest iteration of how to expand telehealth, but essentially the way this came to be, before he retired, this committee, under the leadership of then Chairman Hatch, we produced the Chronic Care Law, which was the first law to acknowledge that Medicare is no longer just an acute care program. It is primarily chronic disease, cancer and diabetes and heart disease and strokes. Anyway, Senator Crapo remembers the centerpiece, and this was something Chairman Hatch deserves great credit for because he worked with Senator Crapo and I. It was completely bipartisan. Senator Bennett, Senator Warner, was the major telehealth provisions in that package. And we were just on our way to kind of getting them implemented when Seema Verma, then Donald Trump's head of CMS, called us up and said, hey, can we use your stuff for essentially the model for the initial round of telehealth provisions and carers and the like? And we were able, Senator Crapo and I and others, to shoehorn that part of the chronic care law, the telehealth provisions, and it really became the Medicare jumpstart for finally getting serious about telehealth. So when you talk to us about these issues, you got our attention, and continue to keep your foot on the pedal, because at a minimum, when we're concerned about inflation, it costs people a ton of money to fill their gas tank and go out and get to a provider. So there are ways to save money here. This is an inflation combating kind of tool. All right, let's see where we are. Let me call out to others in order of arrival. Senator Cassidy, Senator Cardin.
Here.
Senator Cassidy, are you there?
I am here. Do you have me?
Wonderful. Let us hear from you.
Sounds great. Dr. Keller, you mentioned the importance of access to evidence-based services for those with severe mental illness. As we both know, the coordinated specialty care is an evidence-based suite of services for those with first episode psychosis. And it was part of a mental health reform bill that Chris Murphy and I put together in 2016 to expand access. And yet I find out that this access is actually quite limited, even though NIH verifies that it's just what we should be doing. So I've learned in general, Medicaid will cover parts of the continuum, but not a coordinated specialty care comprehensive approach. That every state receives SAMHSA community health block grant dollars, which are required set aside for first episode psychosis that could be braided into the Medicaid dollar to provide the comprehensive access. So I guess my question for you as being on the front line, why has it been so difficult to implement the coordinated specialty care for states and providers? I guess I'll start with that.
Well, thank you, Senator Cassidy, for bringing attention to that. And I want to commend SAMHSA for the set aside for first episode psychosis care. In Texas, we have used that to dramatically expand our capacity. The problem is that it's primarily available to people who are either uninsured, who are served through the block grant, or some people with Medicaid, and Medicaid makes it difficult to pay for it because of the fragmented funding approach that you talked about. So I think the reforms you talked about and the need for Medicaid to have value-based purchasing arrangements and bundled payments to be able to pay for that would make it easier to expand that access. But I think it also needs to be expanded to commercial insurance. This is why parity enforcement is essential, because the onset of schizophrenia, the onset of severe bipolar disorder are not limited to people without insurance or who are in poverty. People with commercial insurance deserve the same access. And I will tell you today, we have a two-tiered system in the state of Texas for people with coordinated specialty care. We have excellent access for people who do not have insurance, and we have almost no access for people who do have insurance unless they want to pay out of pocket.
But let me ask you one that's very troubling. But for those who don't have insurance, what I've heard and what I think I heard you say is that Medicaid and SAMHSA don't really work well together. By the way, you can thank Congress for making SAMHSA do that set aside. But that said, they don't work well together. Yet then you said that they actually have excellent access. So square that for me.
Yeah, absolutely. So the work has been done on the ground in Texas by Texas providers to basically take the set aside, which thank you to Congress for doing that, because that did make it easier for our providers to stand that up. And then they have to do the mind-numbing work at the clinic to do that, and not every clinic is able to do that. So the access for uninsured people through the block grant is excellent. The access through Medicaid is spotty. And really, I do believe you are correct, Senator, the better coordination, and I believe the current SAMHSA Assistant Secretary is working on that. I think for CMS, it needs to be a priority. CMS has so many things going on. If they could prioritize this for expedited sort of work and work on these bundled payment arrangements, that would be wonderful.
Okay, Mr. Williams, thank you very much for that. You spoke about the mental health of people who are dually eligible for Medicare and Medicaid, and that nearly 1/3 of duals have a serious mental illness such as schizophrenia, bipolar, or severe major depressive disorder, a rate 3 times higher than that of the non-dual patient. But dual eligibles have worse outcomes than those who are not dually eligible. And my office has been looking at this, and we have found that if you take a state which doesn't have a dual eligible population compared to one that does, and you take same type of patient in both states, the academic literature suggests that where they don't have two forms of coverage, they actually do better. If you will, giving them the second form of coverage, dividing the care between the incentives for the care, actually ends up making things worse. So any thoughts about that? because the duals do terrible. And is it part of the problem, the fact that they are duals as opposed to only one payor?
Senator, thank you for that question. The needs of the duals population are complex. Administrative barriers disproportionately deter poor and marginalized communities and individuals from receiving healthcare services. Low-income people who have to work long hours or have limited health literacy or...
Oh, Mr. Williams, I'm almost out of time, so let me cut to the chase. Is it possible that actually making them a dual, giving them both Medicaid and Medicare coverage, although you do it because you want to help, may be part of the problem?
Our healthcare system is complex. We need individuals like patient navigators to really help dual eligible Medicare beneficiaries access services. And back to my 3 points that I mentioned in my remarks. Mental health services can be integrated at the site of primary care. So engaging in that primary care office and getting people access to the services and navigating those administrative requirements is important. Second, having qualified providers like peers, community health workers, and others that can be resources to individuals to help them navigate the complexity. And then finally, the sharing of technology and information. Having data at your fingertips as a provider and as a patient are ways that you can navigate those complexities associated with being a dual eligible. And we see promising things with special needs plans, which have been customized to meet the behavioral health needs of many individuals.
Thank you, and I yield, Mr. Chairman.
Thank you, Senator Cassidy. And Senator Cassidy, before you go, let me just note we very much appreciate your leadership on this. Your expertise on all these health issues is much appreciated. Okay, let's see. The next senators in line of appearance would be Senator Cardin, Senator Lankford, Senator Brown, and Senator Daines. Senator Cardin, are you out there in cyberspace?
Senator Bennett is next.
Senator Lankford, Senator Brown, Senator Daines, and I understand Senator Bennett is available online right now. Senator Bennett.
Thank you, Mr. Chairman. Can you hear me?
Yes.
Great. And I just want to thank you and Ranking Member Crapo for continuing this incredibly important work on mental and behavioral health. I listened to some of the discussion earlier, and I just want to thank Senator Grassley and Senator Cornyn for their partnership on these issues. And I really hope, colleagues, that we're able to come together on a bipartisan bill here in the Finance Committee on this really important set of issues. I think we will. I think we can. And I also want to take the opportunity to thank my colleague from North Carolina, Richard Burr. I'm grateful that we're partnering again to address the important issue of parity. But before I get to parity, I want to make an observation about the integration. Colorado has been working to integrate mental health and primary care for years. In 2014, Colorado received $65 million in state innovation model funds to create a coordinated, accountable system of care that improves integration of physical and behavioral health services in over 300 primary care practices. While the initiative was a great success, most practices were not able to keep their integration work going once the federal funding ran out. And I appreciate the witnesses' comments in their testimony about a number of successful models. And I'm also interested in models that might not be mentioned today. Other community-centered, evidence-based models like those across my state should receive our support as well. So, Mr. Williams, could you comment on the importance of centering and establishing these integration efforts, practices with specific communities they serve in mind? And should we make sure that increased reimbursement for integration is targeted toward more than a handful of models?
Thank you for that question, Senator. Yes, I believe that there are many opportunities and ways to ensure the integrative model. As was articulated in the bipartisan report that was released yesterday, there's a broad continuum of ways that you can achieve integration. And doing so ultimately helps get people access to services. Telehealth is obviously a way in which you can ensure where you have a low mental health resource or substance use resource area, you can get access to providers and other individuals that can help those people. And that can be done through very simple means like phone and text. But the solutions that I also mentioned around workforce, around expanding the use of technology, are all ways in which you can provide a wide variety of services to individuals. I think when you look at the models that have been pioneered by groups like the Cherokee Health System in Tennessee that have been federally qualified healthcare clinics, but also have a behavioral health component that is strong within their programs, they blend those two resources together to provide the services and supports for individuals. And they do that in a customized and tailored way based upon these individuals' needs. And so we have the payment policies in place through bundled payments, through capitations that can support this type of care delivery. Making these investments will help increase access regardless of location.
Thank you for that comprehensive answer. I appreciate it. Mr. Dickens, since the final regulations implementing the federal parity law went into effect in 2014, Colorado has worked hard to ensure that compliance across our statewide Medicaid managed care system. Last year, Colorado's Health Financing Department released a report on how Medicaid parity is faring, and I'm proud that our Medicaid system is compliant across the majority of requirements. But they and our Department of Insurance have both highlighted the difficulty in establishing parity for non-quantitative treatment limitations, or NQTLs. This includes non-numeric benefit limitations like medical necessity criteria, network admission standards, pre-authorization, and step therapy. In my view, NQTLs largely affect a patient's ability to obtain the care they need when they need it. And I believe that the improved technical assistance and clear guidance from federal agencies like CMS would give states and other insurers the tools they need to improve compliance. With just a few seconds I have left, Mr. Dickens, in your work at the GAO, have you found areas where better technical assistance and guidance would help improve compliance, especially when it comes to NQTLs in plan benefits?
Yeah, thank you, Senator Bennett. You're correct that we have heard of a number of challenges that stakeholders have in terms of those non-quantitative treatment limits. The Departments of Labor and CMS have over time provided more guidance, more frequently asked question responses on how to address those, but it continues to be a challenge that many stakeholders identify and that the Department of Labor and CMS have identified in their investigations, that there continue to be non-quantitative treatment limits that are different for mental health and for other medical and surgical services.
Thank you. Thank you, Mr. Chairman.
Thank you, Senator Bennett. Appreciate your good work on all of this. Our next four will be Senator Carper, Senator Casey, Senator Warner, and Senator Cortez Masto. And to give our guests a little bit of a situational awareness kind of brief, it's going to get a little hectic around here because we're going to have votes, and both Senator Crapo and I are working on the important Russian trade bill, or cutting off normal relations with the Russians. So we'll be going back and forth, but we're just going to keep this going, and the two of us can do that. Okay, Senator Carper next.
Can you hear me, Mr. Chairman? Can you hear me?
Tom, we can't hear you.
All right, try again, sir. Testing. Can you hear me now?
Yes.
All right, great. All right. I will thank you to our witnesses today for your testimony. Before I want to begin, let me just say again, thank you, Mr. Chairman, for giving me the opportunity to work with Senator Cassidy on this bipartisan working group that focuses on addressing pediatric mental health crisis. I think we've made real progress so far, and I look forward to continuing our work on this important issue with our co-chair, our good friend, Senator Cassidy. Excuse me. I think it's clear that COVID-19 has significantly exacerbated mental health stress on children and youth, as well as a lot of adults, highlighting our nation's acute shortage of mental health services. In my state of Delaware, got over 9,000 Delawareans, ages, I think, between the ages of 12 and 17, who suffer from some sort of depression. However, according to the state, our state students who have access to mental health resources within schools are 10 times more likely to seek care, 10 times more likely. Earlier this year, the Finance Committee heard testimony, you may remember, from U.S. Surgeon General, who stressed that one of the most central tenets in creating accessible and equitable systems of care is to meet people where they are. And for most people, that's right there in schools. Just last week, our Secretary of Health and Human Services, Javier Becerra, and Secretary of Education, Miguel Cadona, announced a joint department effort to expand school-based health services. It's clear that there's a growing momentum to recognize the role that schools already play in ensuring children have the health services and support necessary to build resilience and thrive. We know that investing in schools and community-based programs have been shown to improve mental health and emotional well-being of children at low cost and a high benefit. Good outcome. Mr. Williams, question, please. And any of the other panelists who may want to respond to, but start off with you, Mr. Williams. How can we further improve coordination between primary care and mental health providers to better support our children, including through school-based services? Do you see a role for the federal government beyond providing guidance and technical assistance to state programs? Mr. Williams, please.
Thank you for that question, Senator.
You're welcome.
Connecting primary care and behavioral health is very important to build strong connection between the providers, community organizations, and this is vital for our nation's youth. The current behavioral health crisis is particularly notable for its impact on our nation's youth. Less than half of adolescents with depression over the past year reported being able to receive care, and this was even more acute in Black and Indigenous people of color. Hospitals are reporting emergency room visits among adolescents rising at a high rate. Numerous models that I shared in my written testimony show the power of bringing community-based providers and organizations close to their healthcare system to improve access to services and build that connection. Through integration, expanding the workforce, and using technology, we can improve collaborations with community service providers. They can be just down the hall, as some of the models that we mentioned today, but they can also be a phone call or video chat away. However, there needs to be appropriate financial resources in place to ensure that community-based organizations are not awash with references from the healthcare system. Integrated approaches need to be a two-way street in which the community service organizations and others have resources at their disposal to provide this care and need. And so through things like global payments, capitation, and other approaches, you can ensure that there are enough dollars that can flow to the individuals that would provide the bridge to services that are so important. Thank you.
Yeah, one other quick question, Mr. Williams. In your perspective, how can telehealth be used to better integrate behavioral health care within the primary care setting, particularly for the pediatric population? Go ahead.
Pediatricians are often the first line of defense in many ways. They're trusted individuals that people go to when they have care concerns about their children. And so there's an opportunity there to empower that primary care provider, that pediatrician, to get access to services and do it in a trusted manner. Some of the models that we have reviewed and looked at have provided primary care providers like pediatricians tools and resources so that when they see the first inkling of a potential issue or problem that a child is facing, that they can then appropriately identify the right service for them. And so you try to use these evidence-based models in an effort to connect people to the services that are going to best meet their needs. And you don't necessarily have to have a person in the office, but you can also pick up the phone or use health technology to be able to connect people. So there are many different ways in which you can achieve that goal.
Yeah, Mr. Chairman, if I could, in closing, just note last fall, Senator Corner and I introduced legislation called Telehealth Improvement for Kids Essential Services, TICE, and to provide guidance and strategies to states on how to effectively integrate telehealth into their Medicare and CHIP programs. I think we're on to something, and we would hope we'll have the opportunity to discuss it further at a later hearing. Thank you so much, and thanks
thanks
very much,
for the good work you're doing, Senator Carper, with Senator Casey. So I'm going to run and vote, and Senator Carper and Senator Cassidy are working together, and Senator Casey will be next online. Thank you.
Mr. Chairman, thanks very much for this opportunity to have this hearing. And I wanted to start with Mr. Williams. We know that so many people in our country need the services we're talking about here today, but often they don't access them because the systems that they've got to navigate are so complex. These are seniors, people with disabilities who depend upon both Medicare and Medicaid. We know that over 12 million Americans are eligible for both programs, both Medicare and Medicaid, so-called dual eligibles. 500,000 of those 12 million are in the state of Pennsylvania. Mr. Williams, as you note on page 5 of your written testimony, and I'm quoting here, quote, nearly 1/3 of individuals duly eligible for Medicare and Medicaid have been diagnosed with a serious mental illness. And then you go on to say that the rate is 3 times higher than for those who are not duly eligible. At the same time, they have to navigate 2 completely separate healthcare programs. They might have one insurance card for their primary care doctor, another insurance card for behavioral health, and then a third one for prescription drugs, and the list goes on from there. Earlier this year, Senator Tim Scott and I introduced the PACE Expanded Act, Senate Bill 3626, which is legislation to expand the availability of these programs that integrate primary care, behavioral health, and other services. So my question for you, Mr. Williams, is how would meaningful integration of both Medicare and Medicaid help ensure that people that rely upon both programs can access the behavioral health services that they need?
Thank you for that question, Senator Casey. The administrative barriers that disproportionately deter individuals are high for dual eligible beneficiaries. Having to navigate 2 systems can be difficult. That's a trait that we find that is common across our healthcare system in the United States. Complexity is something we like here in the United States, and it's something that we need to focus on navigating. In fact, the United States is the only country that has a workforce called patient navigators. And those individuals are charged with helping people manage the benefits in which they have and doing it in an effective manner so they can get the services they need. To help dually eligible Medicare and Medicaid beneficiaries, mental health services can be integrated at the site of primary care and can help eliminate gaps in services to providers and community. There's an opportunity for that coordination, co-location, or setting of shared goals that can be used to ultimately develop a care plan for an individual. You also have a host of other qualified providers that can be brought into the care system through these coordination activities. Peers, community health workers, other professionals can be a part of the care team and provide the continuity and coordination to help people over time. And then finally, I say health information technology provides a wide variety of ways to ensure that the data and information that is available is in the hands of both the providers and the patient, making their traversing of the healthcare system that they're a part of easier. Finally, there are a wide variety of plans, special needs plans in particular, that have customized their benefits for behavioral health. And they've shown promise in being able to meet the needs of beneficiaries, both of Medicare and Medicaid, in a good and positive way. So there's lots of complexity, but we have the people, organizations, data, and systems to navigate this complexity. Thank you.
Mr. Williams, thanks very much. My last question is for Dr. Ratzliff. I wanted to ask you about an issue that's particularly important to rural areas, folks in rural areas and communities of color. Community organizations, whether they're faith communities, different workplaces, early childhood programs, schools, are often the first to notice signs that a child or a teen is experiencing a mental health challenge. My question is, how can integrated behavioral health and primary care practices partner with these community-based organizations to connect people with mental health support?
Thank you so much for that question. I'll answer with an example that I have seen in a project we supported in California, which actually for example, a senior center became closely partnered with a primary care organization, and what they actually did is that they could have a bi-directional support for the patients that they serve. So that senior center might be the first place that, for example, depression or anxiety was recognized. They could make sure to try to connect those patients to that primary care organization so they could get access to integrated behavioral health that was located there. And additionally, part of integrated behavioral health is also addressing psychosocial needs, and sometimes those patients needed to be more engaged, to be activated, to get connected to community, to find purpose in their life. And that was where often that organization, that community-based service could be coordinated, be part of the treatment plan really for that patient. So that's an example of how that might work together.
Thanks very much. Thanks, Mr. Chairman.
Thank you. Senator Lankford.
Thank you very much. Y'all, thank you for the testimony today. It's very helpful. I want to drill down on an area we've not talked about much, and that's the Ccbhc program on this. In Oklahoma, we received a grant through the pilot program on there. Our Oklahoma State Department of Mental Health and Substance Abuse then separated out 1,400 tablets to law enforcement, different areas across the state to be able to get immediate response back. What we've seen through that's been pretty remarkable, quite frankly. We've saved about $15.5 million in jail time, and about 82% of the people that would have been headed to jail were actually headed to treatment facilities instead on the street. What I'm interested in is that's what we're seeing in Oklahoma. What are you seeing in other parts of the country for those of you that are tracking that? And is this a model that we can continue to help? When I talk to law enforcement in Oklahoma, they will tell me their jails have the greatest number of people with mental health needs that any other facility in the entire state. And their law enforcement are trying to figure out how to be able to help those folks with mental health issues initially and to get treatment to them the fastest possible way. But obviously, they're a generalist in trying to deal with all things law enforcement and trying to get to a specialist as quick as they can. What have you seen as a response to this in other areas of the country, and what can we do to multiply this? Dr. Keller.
Your neighbors to the south in Texas have seen similar results, Senator. And I think that the essential thing, regardless of what state you're working in, is you need to do two things. You need to be able to get that mental health provider embedded with law enforcement, preferably able to respond without having law enforcement as an option, so that the behavioral health provider, and we found also that paramedicine has helped too, if you can bring community paramedics in there as well. But the essential thing is being able to get that out, and you're right, telehealth works fantastically for that because it provides that expertise out there. But the second thing you need is you need a place for people to go. You have to have treatment in the community, and so CCBHCs are essential for that. So in a lot of rural areas, collaborative care can be for primary care practices there. And what we found is most important is same-day access to a prescriber. And if you can do that and you put those two things together, you're going to see fantastic outcomes.
Okay, that's very helpful. I want to drill down a little bit. I co-sponsors the No Pain Act, which is trying to deal with the issue of opioid addiction and to try to find other treatment options to be able to help those folks dealing with pain. And there are a lot of folks with chronic pain, but to find other options for them as early as possible in the process on that. What are we dealing with right now on trying to be able to help individuals with chronic pain dealing with other alternatives that are non-addictive? What have we seen a rise of, or any other treatments that you've seen?
I can start. Thank you for that question. I think one of the things that we're seeing is that there are alternatives. Some of the medication for OUD treatment can be effective for addressing pain as well. I think that takes a lot of coordination to actually support patients in making the transition into new treatments. And so, again, I think the focus on being able to do that in primary care, where those patients are often showing up, is really critical. Some of the models of integration that we're talking about today are one approach that could be helpful to actually provide that support where patients are often seeking that help from their primary care doctor.
Great. Can I have a follow-up with you as well on this, dealing with areas of rural health care? Dr. Keller just mentioned that as well in the telehealth issues on rural health care. I know this is also an area that you worked on. What can you bring to us as we're dealing with rural mental health care?
Thank you for that question. I talked a little bit in my initial testimony that the collaborative care model and other models of integration have shown to be effective in rural settings as well. We get as good and sometimes even better outcomes in some of our rural practices where we've implemented mostly collaborative care, since that's the model I work on. I can talk about my personal experience of that. At the University of Washington, we actually partnered with a rural access hospital that was in a county that didn't have a single prescriber. So occasionally someone would come in for a day, and that was it. That was what was available in that community. When we implemented collaborative care there, that rural access practice had a primary care practice. We were able to, they hired a behavioral health care manager. Some of us at the University of Washington actually provided consultation or support to that primary care practice. And what we saw is incredible work done by those primary care providers, but they felt really supported having access to people like us that had expertise that they didn't have, in being able to really serve their community. And I think that that was a really powerful example of how you really need to get creative in partnerships and leveraging the workforce in new ways.
Okay, thank you. Thank you all for the work that you're doing on this and bringing this. This has been an important issue for our committee. Obviously, coming out of COVID, there's been greater attention to juvenile mental health, but quite frankly, it's been mental health across the entire country as we continue to be able to process through this. So I really appreciate your testimony today.
Thank you. Next is Senator Daines, and he will be followed by Senators Warner and Cortez Masto. Senator Daines.
Chairman, thank you. I understand this is the fifth hearing the Finance Committee has held this Congress to discuss mental health. As we think about so many Montanans and Americans across our country battling mental health as well as the addiction issues, I do appreciate the committee's efforts here to bring better outcomes for patients. I think everything we're doing here is means to better outcomes, which is going to be the end. The past few months, I've been working with Senator Stabenow. I've been working to develop policy solutions that are going to help strengthen and improve the mental health workforce. The numbers are pretty staggering when you look at the shortages in mental health professionals. Estimates that we have seen is 148 million Americans live in mental health professional shortage areas. That is 45% of our population. And I can tell you in a rural state like Montana, these shortages can even be more severe. As they say, it's a long way between telephone poles in a place like Montana. I'm looking forward to discussing how we can break down some of these barriers and be better at leveraging our workforce to expand critical access to care for patients in Montana and around the country. A few questions. Back home to Montana, we have had a successful peer support network that allows people who have gone through recovery to help others who are battling with mental health or addiction challenges. Nothing's better than having a success story and a role model to help someone else in need. We've seen that peer recovery support leads to reduced hospital admission rates, increased quality of life, and decreased costs to the mental health system. And that's why I have co-sponsored the PEERS Act, which would expand access to peer support services for mental health and substance use disorders. Dr. Keller, why do you think peer support is successful, and what would it mean to patients if Medicare was allowed to cover such services?
Well, Senator, thank you for that question. And I think you explained it actually quite well. People being able to relate to the experience of having gone through something and also having overcome something and having to, even if your symptoms aren't fully addressed or you're still struggling with things, to be able to move your life forward. And that's really the unique value that peers are able to bring. And they should be available in every type of health coverage that we have, including Medicare. And currently they're not. So I think extending that to people with Medicare would basically be an important step with Parity in terms of being able to have the same sort of access that often we have in Medicaid programs. I would also argue that commercial plans should be looking at that more too, because encouraging commercial plans to do that, showing the evidence, it's an excellent way to expand the workforce, and there's unique effectiveness in peers because of their lived experience.
Yeah, well, I appreciate that insight, and I think on the peer side too, it's not only the benefit the person who's being helped, but the person who's doing the helping also further strengthens, I think, their resolve and commitments. I always say, if you want to really learn something, go teach something, right? And then you really become more informed and more stronger passion for the subject. Earlier this month, I worked with my colleagues on this committee to secure the extension of the CARES Act policy, which allowed employers to offer first dollar telehealth. In rural states, again, like Montana, it's critical to ensure that workers and their families have access to affordable care, including mental health services. I was also encouraged to see that additional telehealth flexibilities were extended by Congress so that patients were able to continue accessing important telehealth services no matter where they live. Dr. Ratzliff, how valuable have these telehealth flexibilities been in terms of increasing access to psychiatric care, and moving forward, should telehealth be part of the solution to help address the workforce shortages?
Thank you for that question. I think they've been incredibly important. I have multiple examples from my practices of patients that either accessed care for the first time using telehealth, or really were able to stay connected to really life-saving medications. For example, some of the practices that I'm working with that are providing medications for opioid use disorder, being able to actually continue to access those services probably saved patients' lives. I think that it is very important that we continue to be flexible to allow patients to access the care they want at the time they need it, and ideally the mode that they need it. Many people, for example, find it very helpful to continue working, being able to actually use telehealth as a way to continue to access care and not have to take a whole half day of work off to be able to go to a single appointment. So I think that's very important. I do think that there's an important policy piece that we should think about. In some of the policy work, especially around Medicare, there is a requirement, though, that you have to actually be seen once in person every 6 months. And it is the only, stipulation like that around telehealth care, and I don't know why it's just there for mental health. And so I would urge that we think about changing that, because I think it's, again, a parity issue. I don't know why for mental health there would be that stipulation. That decision should really be between the clinician and the patient to make that decision if that needed to be seen.
Thanks for flagging that issue. I'm out of time. Mr. Chairman?
Daines, we're now on Senator Warner.
Thank you, Mr. Chairman. And let me echo what so many of my colleagues have said about both the value of telehealth, the workforce shortage issues we have, and I agree with Senator Daines earlier, this notional idea that there ought to be different standards on mental health providers in terms of in-person visits versus other providers doesn't make much sense to me. I want to direct my first question to Mr. Williams, and your written testimony was really helpful in terms of coordination between primary care and mental health. And, as we've just discussed and other witnesses testified, the fact that Medicare is actually doing a reimbursement on these consults for telehealth mental health practices makes a lot of sense. But I'm told from practitioners in Virginia that failure to have that Medicaid match is really preventing some of these mental health services to be delivered on a telehealth basis. So, Mr. Williams, would providing a federal match to state Medicaid programs for telehealth consults really help this collaboration between primary care and mental health care?
Thank you for that question, Senator. And yes, providing additional services and supports, dollars to help ensure that people have access to telehealth is important. And I think telehealth, as we have all discussed here today, is a really a positive way that has much potential to kind of ensure that there's access to providers and services. But I think we also must realize that telehealth has not been evenly accessed. Black and rural Medicare beneficiaries had lower telehealth use compared to others. Telehealth use varied dramatically by state, with higher use in the Northeast and the West and lower use in the Midwest and the South. So we have a little bit of work to do to understand those differences. Yes, the expansion is positive and good. It provides an avenue for more access, but there's also the opportunity to ensure that everyone gets equal access. And I just would like to note that the temporary continuous coverage requirement that kept Medicaid coverage intact during the public health emergency helped to ensure access to a wide variety of services, and that should include telehealth. Thank you.
I thank you, and I do think this notion of continuing some level of federal match on Medicaid, I think is on telehealth is important. I want to go to Dr. Keller. I was pleased to see in the 2022 Parity report to Congress that new authorities were given to Department of Labor, Treasury, HHS, and that have led to in increased and improved enforcement. But I was looking through that and saw one health insurer and two of their large plans actually covered nutritional counseling around diabetes. And I've got a type 1 diabetic daughter, so that's very important. But it didn't cover the kind of consultations needed around anorexia, bulimia, and other eating disorders. Unfortunately, I've got a lot of personal family history. The daughter that has those type eating disorders, actually the same daughter's got type 1 diabetes, maybe TMI, but it's just and the number of colleagues and others who are experiencing this has become almost endemic in itself. So, Dr. Keller, what other ways can we look at trying to make sure that and I know there was enforcement action in some part of this area, but what other ways can we do at the initial stage of plan design to make sure that this critical area around eating disorder plans are not discriminated against in terms of coverage?
Well, Senator, I really appreciate you bringing that attention and sharing your experience on that with your family. I would actually like to, could provide some additional detail because there are some specific things around the eating disorder diagnoses that we'd like to share. But I would say in generally, one of the biggest problems that the enforcement is trying to address right now is the fact that we're treating the below the neck physical health conditions differently than the above the neck. And unfortunately, our body's connected. And I think no mental health disorder expresses that more than eating disorders. And I think the example you bring up shows exactly the thing. And the reason is you've got different people in these insurance companies managing those benefits. So on the below the neck needs, i.e., nutrition, they're designing it in a way to try to advance outcomes in a more integrated way. On the above-the-neck psychiatry piece, they're trying to limit those costs and to try to weed out spending more, and they're being very successful. They're spending 20% less than they used to before these things went into place, and unfortunately, the burden is being felt on families. And so being able to continue enforcement is essential for that, and to have the exact same parity, and also have them working across the divisions within the insurance companies to try to end those sorts of siloing. And I think also being able to do primary care-based interventions, whether it's collaborative care, primary care, behavioral health, other integrated models, is essential because we're also not detecting those needs until 8 to 10 years after they begin. And so we put the burden on the family to have to discover those needs and figure out what to do, often in a crisis. And so if we're looking earlier when we're dealing with healthy nutrition, weight gain, other types of things in those well child checks for the child, and we're addressing their mental health at the same time, we're going to find those needs sooner and begin to treat them better, just like we do now for cancer, like we do now for heart disease. We have to get the detection earlier and the care in primary care.
Well, Dr. Keller, I appreciate that, and I hope I could get more information from you. And Mr. Chairman, I'd love to continue working with you and the committee on this very important issue.
Thank you, Senator Warner. We know that this is important to you, and we look forward to working closely with you. Senator Whitehouse. Oh, excuse me. Senator Cortez Masto, I apologize to my colleague, is next. Senator, are you out there?
I am here. Thank you.
Wonderful.
Thank
It
you,
is your time.
Thank you so much for holding this hearing. It is such an important topic that we need to address. I'm so pleased that the Senate Finance Committee is really working on addressing mental health. I am pleased to be able to join my colleague, Senator Cornyn, in co-chairing the subcommittee on increasing integration, coordination, and access to mental health. Let me start with Mr. Williams. We've established that Medicare coverage issues persist among seniors just as they do among families. And if you believe the old adage that as goes Medicare, so goes the market, then the mental health coverage gaps in Medicare have consequences for private coverage too. So, Mr. Williams, let me ask you this. If there was better Medicare coverage of mental health, could we reasonably expect better commercial coverage as well?
Thank you for that question, Senator. Yes, I believe very much so that Medicare sets a benchmark. I started my career focused on Medicare policy, In doing so, working at the National Academy of Social Insurance, I learned that through Medicare policy, the rest of healthcare policy goes. We've seen that consistently with the Medicare Modernization Act, with several balanced budget acts, through the Affordable Care Act. When we use the leverage of the Medicare program, it affects change throughout all of the healthcare system. And we have that opportunity to do and make that same change with behavioral health, which includes both mental health and substance use services. And a vital way in which that can be done is through the expansion of peer support. Certified and trained accredited peer support specialists have been able to help individuals achieve recovery goals and do it in a cost-effective way. And so if Medicare were to expand coverage of that type of provider, that benefit would, one, be available to Medicare beneficiaries, but it would also set the precedent that would be an area of focus and opportunity for the commercial sector. And so, yes, an action in Medicare is great for Medicare beneficiaries. It meets their needs, but it also is the beginning of a chain of change that ultimately will impact the entire healthcare system. Thank you.
Mr. Williams, thank you. And that's why this conversation is so important. And I was pleased to be able to introduce legislation around peer-to-peer counseling programs. So pleased that Senator Daines joined me and we were able to get it passed because we've seen the benefits of really putting in place action around addressing mental health and doing something about it. And the conversations we're having are so important. But let me ask Dr. Keller this because a couple of witnesses have talked about mental health crisis services in the context of parity in Medicare. If you get into a car accident, a paramedic trained in emergency medicine takes you in an ambulance to an emergency room where you're going to be cared for by a physician. You might be admitted a few days, then sent on your way with follow-up instructions. But if you're experiencing a mental health crisis, the ambulance cannot take you to a crisis center. Medicare won't pay for the health providers that are best equipped to treat you in that moment, people like peers or licensed counselors, and they won't pay for your nights in a stabilization facility. They won't pay for the community health worker that helps to set you up with a counselor for ongoing care. So, Dr. Keller, if we're to achieve parity in Medicare, do we need to expand coverage of the crisis services as well?
Well, Senator, thank you for that question, and thank you for your leadership on this in partnership with Senator Cornyn on Senate Bill 1902, which would extend that to Medicare. And it's essential because for exactly the reasons you said, and that really begins at the moment when the person shows up, because not only will Medicare not cover the crisis care, it won't pay for the cahoots person that might be coming to help you with your mental health care, or the right care person. We need to have the Medicare coverage kick in just like Medicaid does now, just like some commercial insurance does now, at the point of crisis, all the way through to the transport and to get the person to the stabilization unit and to cover the full array of crisis services, which do include peers as well as essential providers within that network. And I think it's important on the Medicare side. It is also important on the commercial side. So I think parity across Medicaid, Medicare, and commercial payers in this area, and your bill, I believe, does that, and I think we strongly support that.
And thank you. And I have to thank Senator Cornyn and his staff. They've been great partners on this legislation. Clearly, we need the parity. We need the integration for the very reasons that we are talking about today. Thank you, Mr. Chairman.
Thank you, Senator Cortez Masto, and thank you for all your help in the cahoots effort, particularly the focus on bringing together law enforcement and mental health folks. Your leadership on that was especially valuable. All right, but now we have Senator Hassan, our colleague from New Hampshire.
Thank you so much, Mr. Chair, and thanks to you and the ranking member for holding this hearing, and thanks to all of our witnesses, not only for being here today, but for the work that you do. Dr. Keller, I want to start with a question for you. Too few individuals who have an opioid use disorder are receiving medication-assisted treatment, which is the gold standard for opioid use disorders. Access to treatment is limited by the requirement that providers obtain a special DEA waiver known as the X waiver in order to prescribe buprenorphine. Few providers have opted into this program, leaving even those patients who have insurance unable to access a provider in network. So how has the X waiver limited patient access to buprenorphine prescribing providers?
Well, Senator, thank you for this question, and thank you for your leadership on this issue. Medication-assisted treatment is the single most effective thing we can do to not just improve treatment, but save lives. Right. And our modeling has shown that we could save almost every life if we were to extend it out. And the X waiver is the primary barrier to that because it creates additional hassles that, by the way, those same providers do not have for the prescription of the opioids that cause the addiction. Right. I would also add, though, that if we don't have primary care-based supports like collaborative care, primary care-based behavioral health, we won't have the workforce to help them because it is hard to do MAT.
No, I appreciate that. I think removing the X waiver is one of the critical barriers, and that's why Senator Murkowski and I have a bipartisan Mainstreaming Addiction Treatment Act, which would eliminate the X waiver. So I'm going to continue to push for that, but to your point, we obviously need this to be part of an integrated and collaborative care model. To Mr. Williams, because of the pandemic, the federal government lifted restrictions on medication-assisted treatment, allowing patients to receive remote care and take home additional doses of medication. How did these flexibilities affect treatment outcomes during the pandemic, and what lessons should we take forward as we consider the future of telemental health?
Thank you for that question. We know MAT works. Numerous studies have shown us that. The COVID-19 pandemic gave us an opportunity to see how expanded flexibilities in telemedicine allowed individuals to be screened and put on treatment. The DEA and SAMHSA also made it easier to initiate and maintain MAT, and that was a way that people were able to access services. We saw that substance use treatment facilities offering telehealth services jumped nearly 30%. To 60% in 2020. For mental health facilities, the share grew from 38% to 69%. So there's a real growth in using these tools to access MAT in more effective ways. It's very early to understand the impact of these flexibilities, but we have promising data, actually from Texas, that shows that telehealth-initiated therapy and the restrictions that were lifted increased the prescription fills for individuals. Okay. So we have good data and evidence that's starting to show us that this is maybe a new way in which we can make MAT available to individuals. And I think there's a near-term opportunity to build on this progress to ensure that access is for as many people as possible in the future.
Well, thank you for that, and I look forward to seeing us follow the data more and learn more. Ms. Ratzliff, Dr. Ratzliff, patients are more likely to receive mental health care when primary care physicians and behavioral health specialists work together under one roof. This care integration breaks down barriers to accessing treatment and improves health outcomes, and I've certainly heard from both primary care docs and patients about the strength of these programs. What are the key design factors that make integrated care models work, and how can Congress better support those models?
Thank you for this question. I think there's a couple of key things. The first is that I think we really need a model of how to work together. I think the collaborative care model is a good example, but I would focus on a couple of the principles because I think there's been questions about broader integrated care models. And I would say one of the foundational pieces that maybe we haven't talked about as much is that really measuring that outcomes are actually achieved, and that's a really important piece that we want to make sure is part of any model of integration, that patients are actually getting the kind of care that will result in meaningful change in their life. So that's a really important piece. I think it's also important that there is payment mechanisms, and I applaud Medicare for introducing a mechanism to support collaborative care, but that really acknowledged that there's a lot of work in care coordination, in supporting each other as providers that's really critical to actually pay for. It's not the kind of care that we're used to paying for where it was only direct services, but I think continuing to think about how to expand mechanisms for practices to, especially those that accomplish good outcomes, to receive payment for that care that they're delivering.
Well, thank you. Thank you for your work, and I'll submit a question for the record about integrated care in rural settings in particular. Thanks so much.
I thank my colleague for good work on this. Our next two are going to be Senator Whitehouse and Senator Warren, and that will close the hearing. Senator Whitehouse.
Thanks so much, Chairman, and thanks for holding this conversation. I think it's really important. Mental health parity has been on the books for years, since my friend and fellow Rhode Islander then, Patrick Kennedy, got the parity bill passed in a father-son team effort with my colleague here in the Senate, Ted Kennedy. And yet here we are many years later, still seeing continued failures in parity. And it strikes me that the enforcement mechanism is spread across multiple agencies, with the result that there's no clear accountability at the end of the day. And I'm wondering if the witnesses have thoughts about how best to hold folks accountable for parity violations, whether that enforcement should be located in one place. And I'll just note that if we're able to, had we been able to pass Build Back Better, and depending on what comes ahead, there were actually the prospect of civil monetary penalties for these longstanding violations. I know that underneath it, there's a staffing issue that needs to be resolved, but it seems to me that there's also a lack of pressure from the payers to get to where they should be by law. Let me ask Dr. Ratzliff first.
Well, I do agree that we need to enforce parity. As a provider, I can see the impact of not doing that. For specific policy recommendations, I think I would defer to my colleague, Dr. Keller.
Well, that's a handoff to you, Dr. Keller.
Well, thank you, Senator. Thank you, Dr. Ratzliff. We have to continue enforcement. I do think that centralizing enforcement responsibility to DOL and both giving them the adequate staff resources and also adding civil penalties would be essential. And I think the point you raised, that there has to be a point person on the regulatory side as well. And we found that, we tried to do things in Texas back in 2017, and it is too fragmented. And really, it does take, I think, the federal effort through the Department of Labor to move that forward. We would also argue, too, that amending ERISA to allow DOL to also directly go after the administrative services organizations, the TPAs, because it's not just the purchasers that should be responsible, the group health plans, but also their administrative entities, because a lot of that advice and guidance and lack of parity is coming from their actions.
Thank you. If anybody else wants to chime in, I'd invite you to do that in a response. But, I'll make this a question for the record. If anybody wishes to follow up in writing, that would be great. But with 2 minutes left, I wanted to go to another question, which is that in the mental health arena, which is obviously a very broad one, there seem to be 3 areas where focus would be particularly useful and valuable right now. One is on children's mental health, as we've seen children's mental health issues explode through COVID. The second is in the area of addiction and recovery, as the author with Senator Portman of the CARA bill that first put investment into recovery. I think there's more room for progress in the addiction and recovery space. And the third is in the area of police encounters with people who are having a mental health crisis of some kind, and how we provide support to police departments so that they can better manage those systems and have the resources that they know they can call on when they understand that that is part of the problem that they're going to address. Very often, these people, it's not the first time there was a call. The police officers are aware that there is a problem, but they just don't have the resources to address it. So any thoughts on that, I'd appreciate, and I guess I'll go to Dr. Ratzliff and Keller first.
Thank you for this question. So I would say I think it is really important that we are thinking about all 3 of these populations of patients that are in acute need of mental health services. I guess I would go back to focusing on, I think we need both immediate support. So especially when you think of police encounters, it is important that that person who's meeting that patient out in the community is actually able to interact with them in a different way and actually bring them to treatment, not to incarceration. I think, though, what you need then is a strong service to actually continue to provide access to care. And right now, the main place that they're going to do that, actually for all three of the issues that you raised, is primary care. So I guess I will just come back to really that it's so important to invest in really building up that system to be able to deliver care, to be able to bring in a broad workforce to work together in that space, and to be able to provide adequate reimbursement for that coordination and support of treatment.
My time has run out, so if anybody else cares to answer, if you could do so in writing as a response to a question for the record, I think the chairman would appreciate me not going on. Thank you, Chairman.
Thank you, Senator Whitehouse, for your good work. Senator Warren.
Thank you, Mr. Chairman. So in 2020, 1 in every 5 adults experienced mental illness. For substance use disorder, the figure was 1 in 7. And despite the critical need for mental health and substance use disorder services, few Americans get the treatment that they need. If you ask people experiencing mental illness if they got the help they needed, 1 in 3 said no. And just under 10% of adults experiencing substance use disorder were able to access treatment. Now, there are a lot of factors that contribute to the degree of unmet behavioral health needs, but one of the most egregious is the way that insurance companies flout federal laws requiring them to provide this care. And a big way that insurers restrict access to behavioral health care is by more aggressively subjecting these services to what are called non-quantitative treatment limitations, NQTLs. I know you're all familiar with these. So Dr. Ratzliff, let me start with you. You've seen this play out in your own practice. Can you explain how insurers use NQTLs to create barriers to behavioral health care? And what effect does this have on your patients?
Yes, I'll talk specifically. I've mentioned this example, but I think one of the biggest factors that we've seen is actually having these ghost networks. I mean, really not being able to actually call off of the list that you're given and find somebody that you can actually get care for. And this, again, I think some people, people are already struggling with depression and anxiety symptoms. It's really hard to call multiple people over and over again and never get an answer or never get a response for treatment. So I think that's one of the most, egregious ways that I've seen that play out.
Narrower provider networks, more and more phone calls that you've got to make in order to get approval. And of course, the response here, I assume, is that patients delay care or give up altogether. So we've known about this problem for a long time. This is not the first time this has come to our attention. And in 2020, Congress passed legislation to give federal agencies enforcing our parity laws more tools to evaluate insurance companies' use of these practices. Now, the law also required regulators to review at least 20 plans each year to assess for compliance. In a report released earlier this year, the Department of Labor, the Department of Health and Human Services, and Treasury stated that the specific plans selected for such review were chosen based on existing investigative leads or open investigations into reported violations. So, Mr. Dickin, if I can, I want to ask you, you run the healthcare team at the federal government's watchdog unit, the Government Accountability Office, and you've looked into this issue. If we're trying to understand if insurance companies are following federal parity laws, does it make sense to look only at insurers that have received complaints?
Thank you, Senator Warren. No, we've raised concerns that by only focusing on either complaints or other targeted reviews of health plans, that leaves risk that there could be other plans that are not known. There are a number of reasons why consumers may not be making complaints or be aware of the requirements.
Well, thank you. And, I agree with you on this. I agree that we need to monitor all plans for compliance with our parity laws. It's the same reason a teacher might give a pop quiz. Instead of just focusing on a handful of students who didn't turn in their homework, you give it to the whole class to find out who's doing great, who's having a little trouble, and who is in big trouble. But you only get that if you're able to reach all the way across. Now, Dr. Keller, we're not going to make insurance companies take pop quizzes, but we can do randomized audits. So how would requiring federal enforcers to conduct randomized audits of plans strengthen efforts to identify and eliminate unequal application of NQTLs?
Well, I think you explained it actually quite well, because I think really these are across the board. And the sad reality is that every plan that's been reviewed so far has dramatic gaps. So the only way we're going to be able to enforce across all those plans is if all of them know that there's a possibility, and also that they know that there's a significant possibility. So I would argue we need to actually do more than 20. We need to also make sure that they're in depth, and we need to expand the penalties aligned with them so that in addition to having the test has consequences for the final grade.
I thank you very much for that answer. You know, just focusing on the parity violations, we know that these are dramatically underreported. We cannot rely on complaints as the only signal for that an insurer is breaking the law. I believe in randomized audits. And that's why I'll be reintroducing my Behavioral Health Coverage Transparency Act to require federal enforcement agencies to conduct randomized audits of plans, and at the same time to simplify the complaint process, which makes it easier for patients to report parity violations. Healthcare, including behavioral health care, is a human right, and we must ensure that Americans don't face additional barriers to getting the often life-saving care that they need. So thank you all for your work. I very much appreciate it. I know your patients appreciate it. And thank you for being with us today. Thank you.
Thank you very much, Senator Warren. And to our guests, you know, how fitting that we close 2.5 hours in after we focused on ghost networks, with Senator Warren basically offering the second side of the same coin. I mean, ghost networks and treatment limits are the same thing, and this is going to be a debate now about taking on these big insurers and finally getting this fixed. And for me, and we'll excuse you very briefly, the kind of two relevant, dates were my brother passing in 2002, and he struggled with schizophrenia for years and years, and essentially his internal organs gave out as a result of all of the medicines, the pounding that so many were taking then. And you've heard every night for years on end, we'd worry that he'd hurt himself or somebody else who was on the streets. And then the next big date was 2013, 2008. When Paul Wellstone and Pete Domenici, two people who didn't see eye to eye on everything, we thought, this is it. Liberation. People are going to get a fair shake. Mental health and physical health will get treated the same. And I remember my dad and I looking at the newspaper that morning, Senator Warren, and I said, good for Paul, good for Pete Domenici. I was a young member of the Senate then. And I said, this is for Jeff. This is one that's going to really liberate a lot of people. And here we are, 13 years later, fighting the same problems. The GAO folks tell us 2.5 hours ago that there are these ghost networks. Well, we can walk through the ghost network, but when you're shoved into a ghost network by an insurance company, you're not going to be able to get a provider. You're not going to be able to get somebody to take your insurance. You're often not getting accurate directories, so you don't even know who in the hell to call. And then the reimbursement levels are so low that the patient very often gets stuck with the bill. So we are going to be pushing back on all fronts here. We closed it with another good suggestion from Senator Warren. We've had colleagues raise additional ideas for enforcement. But I just want you to know, and Dr. Ratzliff, your roots in the Pacific Northwest are particularly, helpful because Senator Cantwell is going to be a leader in this. This is the time when we're finally going to take on these big insurance companies, and we're not going to accept the excuses, the stonewalling, and what I saw in Portland, Oregon, where our premier institution basically couldn't even get claims paid until their senator raised a ruckus in the newspaper, and then all of a sudden, Senator Warren, all the claims got paid. So we've been fed a lot of baloney about this. And for those who missed it, I particularly focused on the insurance executive who said, gee, we're just starting to learn more about this. It's going to take more time to get comfortable with it. Well, my message to them is time has run out. Time has run out. We've heard from senators on both sides of the aisle that there's a commitment to getting it fixed. So for 2.5 hours, you gave us a roadmap on how to do it. We thank you. We're going to be calling on you often in the days ahead. And with that, the Finance Committee is adjourned.